Hello, everyone. Welcome to week 1. This week we'll be focusing on 3 chapters, but we're going to begin with chapter 8, which does focus on congenital diseases. When we first look at this chapter, I'm sure it does feel a little bit overwhelming because it does introduce a lot of conditions that you might be unfamiliar with, and some of the findings for these conditions somewhat overlap. So again, the goal is not for you to leave class having memorized a long list of rare diseases. Instead, we want to kind of give you a framework that's going to help you organize what you see. So as you probably already know, as you've gone through a few classes now, and some of you are limited technologists or have some clinical experience, you know that we are not responsible for making the diagnosis. That is definitely out of our scope. However, you do need to be able to recognize when your patient's anatomy, their bone strength, or even their joint stability may be different from what we normally expect. And that recognition is going to affect how you communicate with the patient, how you position the patient. Sometimes it may affect the type of equipment that you choose, and also it's going to ensure that you are caring for the patient in a manner that's not going to cause them additional injury or inflict any injury upon them. So what you'll notice throughout chapter 8 is that we will keep returning to somewhat of a simple question. And that question is, what part of normal development did not work as expected? Once we answer that question, we might or you will see somewhat imaging patterns will become easier to understand. So again, rather than treating every disorder as an isolated set of facts, we're going to group them according to the underlying development problem. This slide, which we have it titled The Problem, 20 Diseases, One Overwhelmed Student. This slide basically shows us why, as a student, we might often struggle with congenital skeletal disease. The names alone can, again, make this chapter a little daunting for you, but you may also recognize that a few of these diseases may be familiar to you by name, and those are things such as Down syndrome, Turner syndrome, achondroplasia, osteogenesis imperfecta, and there may be a few more that stick out to you, while others are probably completely new. So again, trying to memorize each condition separately is usually going to lead to a lot of confusion and frustration. If as you're going through the chapter in your readings, you'll see that the findings will start or begin to blend together, and it will become really difficult to remember which diseases cause things such as short limbs, which diseases causes things such as fragile bones, which diseases cause abnormal vertebrae, or other unusual findings that you might see in the skull. So instead, we're going to try and sort the conditions by the part of development that is being affected. So what I want you to do as you move through the chapter, again, don't worry about recalling every single detail immediately. First, we want to learn how to recognize the pattern, the larger pattern. Ask whether or not the problem mainly affects bone growth and shape, or does it affect the strength of the connective tissue or the body's overall genetic blueprint? Once you're able to identify the category that the disease fits in, the individual disease itself will become a little bit more easier to name or place. So again, think of this as somewhat building a filing system in your mind before filling up the folders with all of the details. All right, moving on. So to make this a little bit easier, what I want you to do is imagine that the skeleton is like a house that we're going to build, or a house that's being built. Every house usually starts or needs a blueprint. Every house will usually need a crew to frame it up, and every house will also need internal reinforcement to ensure that it's sturdy. So the blueprint itself is going to represent the chromosomes. Chromosomes, as you probably learned in high school or in your A&P courses, chromosomes contain the instructions that will guide the development throughout the entire body. So when the blueprint is altered in any way, that's going to affect or will affect not only somewhat the growth, it's also going to affect the bones themselves. So if the blueprint is altered, you might see that multiple body systems might be involved in what is being altered or affected. So the framing crew that we discussed as we're building this house represents our growth plates. So our growth plates, as you probably again already learned from your A&P classes, are responsible for producing cartilage that is gradually going to be replaced by bone, allowing our long bones to lengthen. And as they lengthen, they'll eventually take the shape that they're supposed to be in. Now, if that process is disrupted in any way, the bones may become short, they may be broad, they may be curved, or they may be shaped abnormally in some other manner. The last thing in terms of this house that we're constructing, we're going to look at the rebar. All right, the rebar, when you talk about building, that's the metal or steel rods that kind of strengthen the structure. So the rebar represents the collagen and also other connective tissues that we have in our body. And like I said, rebar is responsible for strengthening concrete from the inside. So it's usually laid down before they pour the concrete. So in a similar way, that is how collagen provides the support and strength to our bones. Also our ligaments, it helps with our skin, our blood vessels, and also other structures within the body. So if the reinforcement or rebar is weak, the skeleton itself may look normal in some ways, but in terms of the strength and the ability to withstand daily things that we do, it may easily fracture. It may stretch or not be able to stretch in certain ways, or it may deform more easily than the normal body structure, as if in the fact that if everything is normal and everything is growing properly, all right, it may deform more easily. So as you're going through this chapter, I do want you to keep that analogy in mind, because we're going to use it repeatedly. We're going to be using blueprint, we're going to be using framing crew, and also we're going to be using the rebar analogy. All right, now we can place some of these major conditions into groups. So we're going to start with three broad groups. The first group is considered to be skeletal dysplasias, or what we're calling failures of the framing crew, or framing crew failures. So in these disorders, the growth plate does not build the bone normally. The bones may be disproportionately short, usually or unusually wide, dense, or they might be irregularly shaped as well. So a chondroplasia is a classic example of this particular group or condition, because the long bones do not lengthen like they should have normally. All right, the second group that we're going to look at is connective tissue disorders or rebar failures. So again, here the internal support material is abnormal. So the patient may have bones that fracture easily, joints that are too loose, or tissues that stretch farther than they should. An example of this type of condition or this type of disorder would be osteogenesis imperfecta or Marfan syndrome. They both fit into this category. All right, the third group that we're going to look at in this chapter includes chromosomal or multi-system syndromes, which we're going to call blueprint failures because the underlying genetic instructions they affected the whole body. The skeletal findings are going to be only one part of that clinical picture. Down syndrome and Turner syndrome are examples of this particular category. All right, now I do know that the categories that I just listed here, they're not perfect categories. Some diseases will overlap, but again, the purpose is not to force every disorder into a rigid box. The purpose is kind of to give you a useful starting point when you see a pattern on an image or when you encounter a patient with one of these conditions. All right, now we're moving on to look at specific conditions or specific case files. So we're going to start with achondroplasia, which is one of the best examples of what we consider skeletal dysplasia. All right, the main problems with achondroplasia is that it occurs at the growth plate where cartilage should develop and then be replaced by bone. Because the process is slowed, the long bones don't achieve that normal length. And that's going to result in the trunk, even though the trunk is going to be relatively preserved, it's going to create disproportionate short stature. A term that you should look at or consider is rhizomelic shortening. All right, that means that the proximal portions of our extremities or that patient's extremities are affected more than the distal portions. In other words, the upper arms and the thighs are shortened more than the forearms and the lower legs. All right, now this matters when you think about positioning the patient because they may have unusual landmarks and distances, and you can look at the descriptions in the textbook. On the images, when you're looking at those images, you might see broad, squared iliac wings. All right, so we're talking about the pelvis area. And the pelvis itself is also described as having what we consider a champagne glass appearance. All right, the hands may have what they consider a trident configuration, and the skull may demonstrate what they call frontal bossing and relative macrocephaly. When you talk about the spine or when it describes the spine, we have shortened pedicles, and also we have decreased distance that can narrow around the spinal cord. So your responsibility as the tech is to adapt. You're not going to force the patient into some of the standard positions simply because the routine protocol describes it. You have to work within the patient's proportions. You have to work within the patient's range of motion, and you also have to ensure comfort while you're still obtaining the required images. The next condition is osteogenesis imperfecta, and this is probably our clearest example of what we consider that rebar failure. So the underlying problem with this condition involves type 1 collagen, which produces the internal support for our bones. When that collagen is abnormal, the bones are going to be less able to withstand the normal stress that we put on our bodies daily. And as a result, the patient's bones may fracture with very little trauma. Radiographically, if we're looking at this, we may see generalized osteopenia. We may see thin cortices, bowed long bones, and also we might see that the patient has had multiple fractures in different stages of healing. For this type of patient, the skull may contain extra small bones within the sutures, those Wormian bones, and spinal curvature for this type patient and the pelvic deformity may also be present. For you as a technologist, this condition is or should change your entire approach when you examine this patient, because a movement that feels routine to us might be painful or may even cause a new fracture for this type of patient. So before you touch or move the patient, you want to explain to them what you need to do. You want to ask the patient or the caregiver how they can how they are usually transferred and what movements should be avoided. You do want to use gentle immobilization and support for that patient. And as you are examining them, you want to ensure that you support the entire extremity instead of pulling on or pulling from one point like we normally do with our traditional normal patients. The reason why this is important to remember is because it's not only about producing a diagnostic image. All right, you have to always remember that even though we want to produce the best image, that's not what it's only about. It's also about producing that image without creating additional harm to the patient. So in a patient with osteogenesis imperfecta, we have to ensure that we're safely handling the patient's body parts throughout the entire procedure. The next condition that fits into one of our buckets is Down syndrome. All right, and Down syndrome, when we're talking about the analogy that we started with, our blueprint, Down syndrome represents a blueprint change because the patient has an extra copy of chromosome 21. So since that the genetic instructions affect the whole body, your skeletal findings are only going to be part of a larger multi-system condition. Cardiac, GI, and also craniofacial differences might be seen in this patient. All right, the findings themselves also that will be especially important to you as a technologist is that the patient might have possible atlanteoaxial instability. So we're talking about, their head instability. That means that they may have excessive movement between that first and second cervical vertebrae. A patient may also be referred for cervical spine imaging, including things such as flexion views or also extension views to kind of evaluate that area a little bit more in depth. Now, the key point is that these are not routine movements that we're going to force the patient to do. If instability is suspected, we want to basically follow the order and departmental protocol carefully. We want to communicate with the patient, their caregiver. If there is a caregiver, we want to communicate with the radiologist, and also we're going to communicate with the patient's provider. We're never going to push that patient's neck beyond the comfortable range of motion, merely because that's what the textbook tells us we need to do to get that position. Other skeletal findings that this patient might have can include that they will have a short or underdeveloped posterior arch of C1. They may have flared iliac wings, so we're talking about the pelvis area. They may have flatter acetabular roofs. the hip area. They may be missing the 12th rib, and also they may have a shortened middle phalanx of the fifth finger. So what you want to remember is, again, however, that our role is not to diagnose Down syndrome from an image. Our role is to recognize the clinical history and kind of understand the associated risk, and also perform this exam in a safe manner. All right, now why does chapter 8 matter for you as the technologist? So this slide here is going to bring the chapter back to our role. Again, you are, and I'm not expecting you to name every congenital disorder from a single radiograph, because again, our job is not to diagnose, but you will be expected to recognize when a patient may require a different approach from your traditional patients. Again, if a patient has fragile bones, that might require you to use a fragile technique. So with osteogenesis imperfecta, with osteoporosis, or with severe skeletal dysplasia, we want to ensure that we're using minimal force and support when we're positioning that patient. All right, dense bone is not always considered to be strong bone. For example, with osteoporosis, it can produce some very dense appearing bones, but those bones are still going to be brittle. When we consider unstable joints, they also can change the protocol. So when there is history of that atlantoaxial instability, so that neck instability, we're not going to treat the flexion and extension views as routine views. All right, when we position that patient, it should be deliberate, it should be controlled, and it also needs to be based on the patient's tolerance. We're not going to force them into a position. When it comes to abnormal body proportions, that also can change some of our locations of landmarks. So centering points and image receptor placement may need to be adjusted rather than simply copying exactly what we do from or for that standard patient or normal everyday patient. Last but not least, imaging itself may reveal an important finding that was not the original reason for the exam. So a chest, spine, or cross-sectional study may show a cardiovascular or neurologic complication associated with a connective tissue disorder. You're not going to independently diagnose it. Again, that's not our scope, but you must be able to recognize when an image needs prompt review, and you also want to, if you notice that, follow the department's protocol in terms of the communication process. All right, now this slide is what we consider, or what I consider, your congenital disease quick reference. And this is just a little chart. And the chart is meant to kind of help you practice pattern recognition. So start with the overall appearance before we focus on one isolated detail. So if the limbs are shortened, the trunk is relatively normal, and the spinal canal appears narrow, first thing we might think about is skeletal dysplasia. If the bones are thin and there are multiple fractures of different ages or different, recovery phases, we want to think about a disorder that is going to affect connective tissue and bone strength. If cervical spine instability appears, along with findings in some of our other organ systems, a chromosomal or multisystem syndrome is probably more likely. A patient with long, slender bones, tall stature, and cardiac history might have a connective tissue disorder such as Marfan syndrome that was listed on the other slide, if they have steepled or punctuated epiphysis, if we're talking about a newborn patient, toward a skeletal, we're going to think towards or look towards a skeletal dysplasia. If they have short stature combined with a webbed neck and cardiac abnormality, that might suggest to us that there's a chromosomal syndrome such as Turner syndrome. So again, I do want you to notice that we're not using one finding to make a diagnosis, and we're not making a diagnosis, but we're going to combine a distribution of proportions, bone density, and also clinical history. And this is the same habit that you should use throughout radiology. You're going to look at the full pattern, not just one abnormal looking structure. All right, before we move on to the next chapter, we're kind of going to give a little bit of a summary of what I consider the most important ideas. First, you want to sort before you try to memorize. Ask yourself whether the main problem involves the blueprint, the framing crew, or the rebar. All right, and that question is going to give you a starting point. Second, in terms of skeletal dysplasias, they mainly change the shape, the length, and the density of the bone. So connective tissue disorders affect the strength and flexibility of supporting structures. Chromosomal and multisystem syndromes affect more than the skeleton. So the osseous findings might be understood within a larger clinical picture if we can just look at the big picture. All right. Third, in terms of patient care, that's not separate from image production. For several of these conditions, how you transfer the patient, how you position the patient, how you immobilize the patient, and also how you communicate with your patient is going to be just as important as the exposure or the image itself. Last but not least, again, don't look at this chapter and become frustrated or get a lot of anxiety when it comes to the condition because it doesn't seem to fit into one of those three categories that I gave you. Biology itself doesn't always follow a neat, I'll say, classroom division. All right, the framework that we're providing you with, or that I'm trying to provide you with, is just a tool to kind of help you reason, not necessarily a substitute for learning the individual condition. All right, so as you're studying, keep three categories in mind, and we'll now use somewhat of a sorting approach when it comes to diseases, especially diseases of the joints. All right, now we're going to move on to chapter 9, which are arthrides. All right, arthrides, we're moving away from congenital development and we're moving into joint diseases. All right, so arthrides basically simply means the different forms of arthritis. And I know that you're probably familiar with the term arthritis. So many types of arthritis can produce pain, stiffness, swelling, and also limited motion. So the patient's symptoms alone may sound to you very familiar, because I'm sure you know someone, or you may have a family member that, or you may have arthritis. On imaging, however, that pattern of joint involvement does or can help us separate one category from the other. So chapter 9 is going to focus on three major ways a joint can fail. The joint may be attacked by the immune system. It may be irritated by what we consider crystal deposits, or it may gradually wear down or be worn down by mechanical use, so everyday use. All right, and these processes are going to leave different signatures when it comes to imaging. So as you look at each condition, as you're going through this chapter, I do want you to pay attention to distribution. You're going to pay attention to symmetry, bone density, joint space narrowing, and also the type of erosion or bone production that's present. Those features are often more useful than just trying to memorize a long list of individual diseases, just like we did in chapter 8. So again, like we sorted the congenital diseases by what went wrong during construction, for this chapter, we're going to sort arthritis by how the joint is being damaged. All right, so here are the 3 categories for this particular chapter. So I want you to think of the joint as somewhat of a machine that has surfaces that must glide against each other smoothly. All right, cartilage covers the end of our bones, and synovium lines our joints. All right, ligaments provide us with stability, and synovial fluid reduces friction as those bones are gliding together. So in inflammatory arthritis, because I told you to think of the joint as the machine is being attacked from within. So the immune system targets the synovial lining, and as a result, it produces chronic inflammation that gradually damages the patient's cartilage and also their bone. All right, moving on to the crystal-induced arthritis. Materials basically fall out of the solution, the synovial fluid, and they collect in and around the joint. So you can think of this as what we call grit or sediment entering, if we're talking about a machine, entering a gearbox. Those crystals will irritate the tissues, and they may cause sudden severe attacks. So, again, your patients with arthritis some of them are in pain. All right, now moving on to the degenerative joint diseases. The problem is with mechanical wear in this particular category. Over time, cartilage thins, and our body responds by producing things like sclerosis, cysts, and also osteophytes. And this is basically similar to, if you think about a tire, it's similar to wearing down the tread of a tire as you're using or driving your vehicle. In the body, we're wearing down the cartilage as a result of use over the years. So these 3 mechanisms that you see here, immune attack, crystal deposits, and mechanical wear, they are going to produce different patterns. So our job is to learn what each pattern looks like and how it might affect the patient's positioning. So a severely painful joint may not tolerate the full rotation position that you need the patient to get in. So again, with this patient, you want to communicate with them clearly. And just like when we were talking about the congenital diseases, we may need to adapt our position, but we're going to adapt the position in a gentle manner as to not cause more pain or cause harm. All right, now when we're looking at arthritis, if you read the distribution before you read the little tiny details. So ask which joints are involved. Then you want to ask whether or not the process is symmetric. And then you want to ask whether one joint or whether many joints are involved. In terms of the inflammatory arthritis, such as rheumatoid arthritis, often it's going to involve small joints on both sides of the body in a relatively symmetric pattern. With these, early findings might include things such as soft tissue swelling and osteoporosis near that joint. They also may have what we consider marginal erosions and uniform joint space in terms of narrowing might occur for this patient. All right, the next group is crystal-induced disease. An example of this is the condition gout. I know some of you may have heard that with some of your your elderly people in your family. This particular disease or arthritis is often usually going to be asymmetric, and it might start in a single joint. With it, the erosions may look punched out, but the joint space itself can remain somewhat preserved until later on in that disease process. With this patient, calcification might also be present depending on the type of crystal deposits that have occurred. All right, the last group there is degenerative joint disease. Typically, this one also is going to produce asymmetric narrowing where the joint bears the greatest load. So you might also see in this patient osteophytes, you might see sclerosis, and you might also see cysts. So unlike the inflammatory arthritis, the bone is not usually going to have or appear osteoporotic around the joint. So again, the first questions should be when you're looking at these images, is it symmetric? Is it affecting one joint or is it affecting many joints? Another question you're going to ask is the bone becoming less dense? Is it staying normal or is it becoming sclerotic? And those questions are going to help narrow down the possibilities of what it actually could be a lot more quicker. Again, we're not here to diagnose, but there are some things that we see on images as a tech over years and years and years of doing x-rays that we can kind of identify, not diagnose, but identify. All right, rheumatoid arthritis. Rheumatoid arthritis is what we consider an autoimmune disease. And with this disease, the synovium becomes chronically inflamed. And the abnormal synovial tissue itself, called pannus, grows around the joint and it gradually destroys the patient's cartilage and bone. Now, the distribution is one of the strongest clues when it comes to rheumatoid arthritis. Typically, it's going to affect joints on both sides of the body in more of a symmetric pattern. The hands and the feet are one of the most common areas that are affected early on. On a hand exam for these patients, pay close attention to the MCP and the proximal IP joints. The distal IP joints are usually less characteristic for rheumatoid arthritis. The earliest radiographic sign for this type condition might be fusiform soft tissue swelling. As the disease progresses for the patient, increased blood flow and disuse can produce articular osteoporosis. So again, uniform joint space narrowing and marginal erosions may then develop. And then in terms of late disease, it might produce ulnar deviation, swan neck deformity, and also gluteal deformity. There are special hand projections such as the Norgard and the Brewerton views that might be ordered to help demonstrate those erosions. Again, with this patient, you're going to position carefully because the patients may have pain. They also may have limited mobility. They also might be really stiff. So remember that rheumatoid arthritis affects the cervical spine as well, and it can contribute to anteroaxial instability, so neck instability. So when cervical flexion and extension views are ordered or requested, you're going to use the same caution that we discussed when we talked about in chapter 12. We're not going to force that patient into the flexion and extension views. We're going to carefully allow them to position or go to, what is comfortable for them. All right, next is gouty arthritis. So gout, again, you may have heard of it in the past, is caused by deposition of the urate crystals that are in and around the joint. So it often can present for that patient as a sudden, very painful inflammatory attack. All right, so the patient's body part might be swollen. Now, the classic site is the first metatarsal phalangeal joint at the base of the big toe or the great toe. And when it presents there, they call that podagra. In terms of the imaging pattern differs for rheumatoid arthritis. Gout is commonly asymmetric and also might be monoarticular, especially early on. The joint space itself, when we talk about gout, is usually preserved until later on in the disease process, and then the surrounding bone usually doesn't show the same type of osteoporosis that we see in rheumatoid arthritis. All right, when the patient has chronic gout, you might see soft tissue masses called tophi. With those, the erosions are often going to be paraarticular, and they usually have sharp, defined sclerotic margins. All right, they might have an overhanging edge of bone that projects over the erosion as well, and they can create what we call a punched out appearance. From a patient care standpoint, I do want you to remember as you're positioning patients that, we're coming to rule out things such as this. Remember that when the patient has an acute gout attack, it can or does tend to be extremely painful. So even the light pressure from you placing their body part on an image receptor or positioning sponge or your hand itself may be difficult for the patient to tolerate. So you do want to ensure that you explain the procedure that you're going to do step by step. You do want to support the extremity, and you do want to only obtain or only do the movement needed in order to get the projection that you need. Again, don't interpret limited motion as a lack of cooperation when it comes to these patients, because they might be in a whole lot of pain and they're not going to be able to tolerate what you're doing. Just like with the broken bone, the positions that we could normally get very easily for a patient with a broken bone, same here, a patient that is experiencing an attack of gout, they may not be able to get in those positions that we need them to get in. All right, next is DJD, degenerative joint disease, or what we call osteoarthritis. All right, this particular disease develops as articular cartilage breaks down over time. So it's usually strongly associated with aging, repetitive use. It can be associated with prior injury, altered mechanics, and also weight-bearing stress. With this condition, the joint space narrowing is usually asymmetric as well, because the cartilage wears most at the area where we are receiving what we call the greatest load. So in the hip area, for example, the superior joint space commonly narrows for this type disease. This does or is different from inflammatory arthritis, where the narrowing tends to be more uniform. All right, the body itself is going to stabilize the joint by producing new bone at the margins. And when it does that, it creates what we call osteophytes. Increased stress beneath the cartilage will produce what we call subchondral sclerosis, sometimes described as what they call hibernation. Cysts may also form, and the overall bone density is usually normal or increased rather than considered being osteoporotic. For you as the technologist, DJD is something that will be common for us to see. It does sometimes limit the patient's positioning. A patient with severe hip or severe knee arthritis may not be able to rotate that limb fully or extend that joint fully. So we're not going to force the patient into what we consider the ideal position that we need, because it's going to cause them unnecessary pain. We're going to try to modify our setup in order to try and preserve the diagnostic purpose of the projection. Again, if they're not able to get into the position, again, we're not going to force them, but we will document any limitation according to our department policy when it comes to documenting. Like if the patient could not hold the position, you're going to do your best to get the image, and then you're going to document within the patient's chart the reason why you weren't able to do that. All right, so in terms of chapter 9, why do you think the information in this chapter matters? All right, so this particular slide summarizes basically the fastest ways for us to begin sorting out that arthritis. And that's going to be distribution and also bone density. So first, again, we want to determine the process. Is it symmetric or is it asymmetric? All right, bilateral symmetric involvement of small joints strongly suggests that there's an inflammatory process. A single inflamed joint and irregular patchy distribution or disease concentrated at a weight-bearing surface points more towards crystal depositation or degeneration. Next, or second, we want to look at the bone around the joint. All right, when we talk about articular osteoporosis, is an important clue for rheumatoid arthritis. In osteoarthritis, the bone beneath the damaged cartilage becomes denser, and it's going to produce what we call subchondral sclerosis. And in terms of gout, the bone density might remain or appear normal even when some of those erosions are present. You also want to remember the C-spine. With rheumatoid arthritis, it can weaken the supporting structures around C1 and C2 of the neck, and if it weakens, it's going to create instability. In terms of flexion and extension views, they should be performed carefully and only within the safe range of the patient. We're not going to force their neck into a position. All right, last, positioning again is not just a way for us to display the disease, all right, because that's probably already going to be obvious. All right, certain projections are going to be or will help us because they're designed to reveal or show those subtle erosions early on, or more earlier on than what we consider our standard views. And this is why you have to understand the reason for the order, and also why that order is going to matter for the patient. When you know what the image is intended to demonstrate, then you can position with greater precision for the patient. All right, just like with chapter 8, we kind of made a little quick reference. So you can use this chart as kind of a comparison of some of the common patterns. Bilateral symmetric erosions in the small joints combined with Periarticular osteoporosis, that should make you think about inflammatory arthritis. A single painful first metatarsal phalangeal joint, so we're talking about the big toe, with a punched out erosion and no osteopenia is most consistent with gout. Asymmetric narrowing at weight-bearing surfaces, especially when that's combined with osteophytes and subchondral sclerosis, tells us or should point us to DJD, or degenerative joint disease. Let's see, in terms of the younger patients, sacroiliitis in younger patients with chronic low back pain, that can suggest congenital inflammatory arthritis. Something that we also think about or should know about, or we'll see later, or maybe we saw it in our procedures class, is ankylosing spondylitis. All right, the next one, bronchocolineus. It's a hard word to pronounce. Chondrocalcinosis refers to calcification within the cartilage. Often this one is associated with calcium pyrophosphate deposits. With that, we have cloud-like calcification around the shoulder. And again, when you're looking at these patterns or looking at these diseases, the patterns alone, they can't stand alone for the diagnosis. The radiologist will combine the images with the patient's history. There may also be some laboratory findings that they need to look at, and then also some clinical examination that's done to kind of pin down what the actual disease process is. All right, your contribution to the whole theory or the whole diagnosis, again, is for you to produce that properly positioned, well-exposed image that's going to show the joint spaces, and also it's going to typically show the surrounding joints of that patient clearly. When the patient can't tolerate our routine positioning, again, we're going to communicate that limitation that the patient has via documentation so that the patient's images can be interpreted for their diagnosis. Now we're going to transition to the very last chapter that we needed to focus on for the week, and that chapter is trauma. So unlike chapter 8 and chapter 9, where we're sitting there trying to sort out diseases by a developmental or pathologic process, trauma is a little bit easier. Trauma requires us to describe exactly how the structure failed. So a fracture description from the healthcare team is usually what's given, possible mechanism of injury, and then also a step in how we're going to manage the patient in terms of how we're going to immobilize them, or maybe sometimes it may require surgery. So there were a lot of terms in this chapter. All right, the words transverse, oblique, spiral, comminuted, impacted, and avulsed are not interchangeable terms. Each of those terms, as you look through the chapter, they tell you a specific type of fracture or a specific type of fracture line, and also sometimes it can tell us the relationship of the fragments of that fracture. So as a technologist, you're going to obtain, typically we're going to obtain at least 2 projections at right angles of each other whenever possible, sometimes 3 or more, because a fracture can sometimes appear different from one view to the other, especially if it's not displaced So we have to include in those particular images all of the anatomy, all of the appropriate anatomy. If we suspect a fracture, we are going to avoid unnecessary movement of the patient. And we're also going to recognize when the patient shouldn't be repositioned without additional support. All right, so again, the trauma chapter focuses on three things. It had a lot of vocabulary, and that vocabulary was used to describe the fracture. It went into the special appearance of the injuries, especially in children, and then also the normal stages of healing. So those concepts help us better understand why certain views are obtained or ordered, and also what follow-up images are usually expected to show in terms of fractures. So here's some of the vocabulary that was in chapter 10, trauma chapter. So think about for this chapter, or for trauma, or for a fracture, think about trying to describe a crack in a glass. So you wouldn't simply say sometimes that the glass is broken, all right? You might say that the crack runs straight across. You can say that the crack travels at an angle. You can say that the crack maybe spirals around a point, or you can also say that the glass is shattered in many pieces. So fracture terminology works in the same way. We don't just say that the person has a fracture, we have to describe a fracture. All right, so we're just going to pick a few of them to kind of describe. So the three are listed here. First one is a transverse fracture. All right, with the transverse fracture, and you can look at the pictures in your book, they run perpendicular to the long axis of the bone. All right, if we were talking about an oblique fracture, the oblique fracture crosses the bone at an angle. If we're talking about a spiral fracture, the spiral fracture wraps itself around the shaft of the bone, often reflects that there was some sort of twisting or rotational force. In terms of comminuted fracture, that one consists of more than two fragments. All right, the next one is green stick and torus fractures. These are considered to be incomplete injuries. They're usually seen most often in children because the pediatric bones or children's bones are a little bit more flexible than our adult bones. With an avulsion fracture, we have a tendon or a ligament that pulls a piece of the bone away. With the compression fracture, that one occurs when the bone collapses under pressure. And then also in terms of the compression fracture, if we think about the spine, that's when we see like the vertebral body kind of shorten, not be as tall as the rest of the vertebral bodies. In an impacted fracture, we have one fragment that is driven down into another fracture. I'll say that one's kind of similar to, in my opinion, if I have to think about it, a compression fracture. All right, when we're looking at an image and we're looking at fractures, what we do, or what we try to do, or what the radiologist will try to do, is describe what's actually present. All right, they also consider displacement, they consider angulation, they consider rotation, shortening, and whether or not that fracture is what we consider open or closed based on the clinical information that was given to us or to them. Our images should include the entire area of interest or entire area of concern, and it should also demonstrate proper alignment without causing additional movement to that injury site. In terms of pediatric incomplete fractures, again, we already stated that children's bones, they're more flexible. They contain more collagen than our adult bones. So they may bend, they may also buckle instead of completely breaking like our bones do. All right, with the green stick fracture, which was listed on the other page, one of the cortex breaks while the opposite cortex remains intact and it bends. All right, the name of this comes from, let's say you grab a little small green thin branch off of a tree. When you try to snap a fresh green branch, again, one side cracks, but the branch doesn't separate completely. So on an x-ray, when we're looking at a green stick fracture, we want to look for the disruption of one cortex without bowing on the other side. With your torus or your buccal fracture, usually it occurs when there's some sort of compression that causes the cortex to bulge. There might or may be no obvious fracture line when we're talking about a buccal fracture. The injuries are common in terms of buccal fracture near the distal radius after a fall, or like the little kid falls and tries to catch themselves on their outstretched hand. And the findings, they probably or may only be a subtle bump or irregularity at the cortex. All right, the fractures that we mentioned here, green stick, torus, buccal, they can be an easy miss if the images are not rotated properly. If the images are underexposed, or collimation sometimes can cause some concern for seeing some of these fractures. So what we want to do for these children is obtain the views and inspect both of the cortices carefully before we release that patient. If the patient has focal tenderness, but the injury is not obvious, you don't want to dismiss that concern. The radiologists themselves are going to interpret that exam, but you as the technologist, you want to ensure that the correct anatomy is included, and you also want to make sure that the image quality is adequate enough to show those subtle cortical changes in that patient's bone. Okay, now we're going to move on to the stages of fracture healing. So let's kind of reflect back now on that construction analogy that we started with. So once a fracture occurs, the body does begin a repair process, and that repair process uses many of the same cells and materials that are involved in normal bone formation. The first stage is hematoma formation. So damaged blood vessels bleed, and of course, a clot develops at the fracture site. Next comes inflammation. So during the inflammatory process, inflammatory cells remove damaged tissue, and granulation tissue begins to bridge over the fragments. All right, the third stage is considered or called callus formation. So a soft callus will eventually develop, and over time it will gradually become mineralized, and this will typically be visible on the radiographs after a few weeks. You'll start to notice new bone around the fracture site. During consolidation, woven bone is going to be replaced by stronger lamellar bone, and the fracture over time will become a lot more stable. Last but not least, we have remodeling. And remodeling is a continuous process. It continues over months and even years as the bone begins to reshape in response to stress. You'll see that it will eventually go back to its original form. Now, in terms of the healing process itself, the healing speed is going to vary. Um, Cancellous bone typically heals a lot more quickly than the dense cortical bone. In terms of patient categories, children usually heal a lot faster than adults. And then there are some things about our lifestyle or our body conditions, such as smoking, if you have diabetes, poor nutrition, if infection has occurred or set in, advanced age, and also impaired blood supply, all of those things can delay the healing process for the bone. One thing that you do want to think about or take into account as the radiographer on follow-up imaging, the things that are going to be important for the doctor or the radiologist is they're going to be looking at and comparing bone alignment. They're going to be looking at that fracture line, callus formation, and also evidence of if there's any complications or not. So you as the technologist, your positioning should somewhat mirror what the initial positioning was. Once they stabilize the fracture, splint it, or cast it up, when they're coming back in for their follow-up exams, you want your images to somewhat mirror the positions that the initial images were in. That way, the doctor can closely monitor where they saw the initial fracture, and then also they can compare what they see from day one to whatever day or week or month it is in the healing process. All right, so why do you think trauma imaging requires for us to be so precise? In my opinion, trauma imaging does require careful techniques. The reason why those techniques should be taken into account is because a clinically significant injury might not be obvious on the first exam. Some fractures we consider to be occult. What that means is they're not clearly initially visible. Your patient may have focal pain and a strong mechanism of injury, even though the radiographs appear to be normal. As that healing process begins, what we'll see is the resorption of those fracture margins or that callus formation might make that injury a little bit more visible on later images. So this is why a negative first study doesn't always end that clinical evaluation for the patient. Pediatric incomplete fractures are another challenge, and that's because of the abnormality or the subtleness of their breaks. All right, so some of the things that they look for are bowing, buckling. They look for those small cortical irregularities rather than only searching for a fracture line. Fracture orientation might also provide information about the mechanism. A fracture that occurs with minimal trauma or in an unusual location, it might raise concern for a weakened or pathologic bone. So the radiologist will make that determination, but your images must show that lesion and also surrounding anatomy clearly. Finally, in terms of healing, healing should progress over time. Follow-up studies may be ordered, typically are ordered to assess or look at alignment, callus formation, union as well. And again, we want to reproduce positioning that's consistent and avoid removing immobilization devices unless the order or the provider or the department protocol tells us to or allows us to. All right, so that concludes our chapters for the week. We had 3 chapters, 8, 9, and 10. Chapter 8, some of the things that we wanted to ask ourselves is what failed during development. what is the genetic blueprint, the growth plate framing crew, or also we looked at that connective tissue rebar. That framework should have helped us understand congenital differences in bone shape, bone strength, and also stability. With chapter 8, we were asked to ask how the joint was being damaged. So was it being attacked from within by inflammation? Was it jammed by crystal deposits? Or was it worn down by mechanical use? We wanted to look at distribution and symmetry, also density and joint space changes kind of can help us separate those different patterns. Last but not least, our trauma chapter, chapter 10, we need to ask ourselves what force did the bone undergo and how far the repair process progressed. Precise fracture terminology is typically going to be needed, and also consistent follow-up imaging to allow the healthcare team to evaluate the injury itself and also the healing process or the healing progression. So with all 3 chapters in mind, we should have the same professional habit in the back of our mind. Same professional habits apply. Don't simply perform the routine by memory. We're going to look at the patient's history. We're going to look at and observe their mobility and their body structure. We're going to try and understand what the ordered images are meant to demonstrate, and we may need to adapt to the patient's condition, all right, in order to make them as comfortable as possible and perform the exam as safely as possible. All right, an image typically is not going to be successful. I'm not going to say it's not going to be successful, but we do want to avoid causing further injury or inducing further pain if possible throughout the imaging process. So our goal is always to create that diagnostic quality image, but we want to always think about the patient and combine that with adapting to their condition and providing the most comfortable, least painful care as possible.